G'day and welcome back to Endo Untangled. I am Dr. Alicia Macro, a GP with a special interest in women's health, and I'm joined, as always, by my friend and colleague, Cherie Noble, who is an accredited exercise physiologist. We have a special guest today, and I don't think I'm speaking too far out of turn by saying probably one of our favourite people in the endometriosis kind of world.
Agreed.
Is Professor Louise Hull. She is a distinguished gynaecologist and a reproductive medicine specialist based in Adelaide. She is a scientist. She leads the endometriosis research group at the Robinson Research Institute and practices clinically at Embrace Fertility and at the Women's and Children's Hospital. Her academic journey includes a PhD in endometriosis from the University of Cambridge. And she has been instrumental in initiatives like the Image Endo project, which we will be talking a bit more about shortly. And in her spare time is an international ambassador for the World Endometriosis Society.
She's kind of a big deal.
Absolutely. Professor Louise Hull, thank you so much for your time and welcome to the podcast.
Fantastic. Thank you so much for that introduction. I do appreciate it, but it's more that's, you know, I've done a lot of science and a lot of medicine, and it's mainly been about endometriosis, so in lots of different ways. So it's been a fascinating journey, really.
Yeah, can't wait to unpack some of that with you today, Louise. And really that's where I wanted to start, because I've actually heard you talk on some other platforms about, you know, had a slightly wiggly path into becoming a gynaecologist, and you went through science first. I'd love if you could tell us a bit more about how you got from, you know, there to here.
Yeah. So I'm actually a New Zealander. So I grew up in the South Island of New Zealand, and had hoped to do medicine, but actually didn't get in and ended up going into basic science, which at the time I was like, oh my goodness, I didn't get in. But in actual fact, it really opened a lot of doors, and I learned a lot about basic science. And it was the early days of genetics and biochemistry, and a lot of new developments were being made in science. So it was a very exciting time. And then as I came out of science, I ended up getting into medicine as one of the very first older intake students, and they were just starting to really let a lot more women into medicine as well. And as we progressed through medicine, the IVF industry also started. So I was really at the beginning of all these really exciting times, and fertility in those days was very, very centered on science. We really didn't know much about reproduction at all from a biology point of view. And it really opened up, and having that background really made a huge difference. And then I had that opportunity to go to Cambridge and do a PhD in endometriosis, which we really did not understand very much at all. And they were just starting to do array work, and some of the work we were doing with microarrays and some of the models we had were very novel in the field and very novel in the world. And we started really learning about all these really different biological processes associated with endo, and that was really fascinating. And then that sort of opened up further and further, and suddenly we could look at different treatments, and we can look at different ways of diagnosing and different aspects. So it's been a really long journey, but I would sort of feel like I was really in the right place at the right time in lots of ways. And again, I ended up coming back to Australia and doing a lot of work here. And then Australia's really been pretty well known for the National Action Plan. It was one of the first times a country has really looked at endometriosis as a condition and started funding and actually even just apologising to people who've had endo and how poorly we have researched it and tried to understand it, and how it was so far behind all the other diseases that we look at. And that really opened up in Australia before the rest of the world. So there were lots of opportunities there to really, you know, we were in such a low bar of what we knew. We could learn so much so quickly by just doing some simple things with some good funding, that it really, we could explore lots going forward. And it really has opened up a lot. And people can talk about it now even. When I first started, you couldn't talk about fertility, you couldn't talk about periods, you couldn't talk about pelvic pain. It was just such a taboo area, and people would have endometriosis or pelvic pain and they really couldn't even express it. And sort of there was a lot of denial that it was even a thing. And thank goodness that awareness has really, really changed. And I mean, podcasts like this are very much part of that we can have that conversation and men can be part of that conversation. It's not just a secret women's business. We can actually talk about it as professionals, as mature people, as adults, and understand that it's a biological process that some people get and that we still have to look after and treat. And it's just such a better way of, being part of a clinical world in that too. And I'm sure you find that too.
Oh, look, absolutely. And wow, so much to unpack there already. I mean, one of the things I've just to pick up on what you said around the National Endometriosis Action Plan, and the way that you frame almost as there was almost an apology there, or was there actually an apology there?
Yes. So the Minister of Health at the time was Greg Hunt, and he actually came in. I was actually at the workshop for it, and he came in at the very beginning and he gave a formal apology to the women of Australia at the front end of that workshop. And that was the first time anyone had really acknowledged how little had been done in that space. So it was a really very big moment for the endometriosis community. And I was just very lucky to be sitting at the table, able to listen to it.
So when was that approximately? Like, I'm just trying to think, sorry to not know my history well enough.
Yeah, I'm trying to think too.
Yeah.
It was, it must have been about 2018, I think.
Oh, so not that long ago.
Yeah, it was before COVID. But yeah, it wasn't that long ago. It was, it was not 10 years ago.
That gives me goosebumps. And I think so heartening to hear as well, that sort of sense of starting to acknowledge what women have been going through and what has not been listened to and what has not been even allowed to be discussed up until quite recently is quite shocking. And I think there needs to be more of those discussions happening. And
But also just if you look at the clinical care and how that's changed just from that time, when they started putting some funding in, we now have clinics that specialise in endometriosis, the Endo 33 clinics. We've just had 5 or 6 new medications go onto the PBS that can treat endo, and we haven't had a new medication for 13 years. The amount of research that's being done in endometriosis, it's never been done before. And also we've never really had private funders consider endo a topic that they would put money into, to philanthropic money, and they've had a huge grant for that as well. So it's just it's changed so much in terms of it's seen as a valid condition to research and treat and have proper clinics for, and looking at teaching now, I think, is the next step, that they'll look to try and put better teaching in for medical students and allied health and GPs as well. So there's lots sort of that has changed in such a short time. But the previous 15 years before that, nothing changed much. We did a lot of research and we got some biology out, but it was to actually change clinical practice was virtually impossible at that time.
Yeah, that's amazing. And perhaps that might be a good way to segue into hearing a bit more about perhaps your original research, because you were really involved in some of the very early days of learning about endometriosis, including some early mice models and things like that.
Yeah.
And you were talking about arrays before, and if you could tell us a bit more about that, particularly perhaps for someone who doesn't have a science background, if we could, talk us through it.
So in the late 90s, really, they were just developing methods where they could break up all the DNA and RNA and extract it and run multiple assays at once on a platform. And that was called a microarray. And you could, instead of, look at one messenger RNA and measuring it, you could actually measure hundreds and eventually thousands, and it eventually became sequenced. The whole lot were measured, but we suddenly could work out all the different things that changed in endometriosis. And so then you could work out what cells were involved and how the process changed over time. And we used our models to look at how the lesions changed over time. which we couldn't do in humans because we had to do surgery every time we wanted to find out about it, and we didn't know where they were in the process of development. So then we could actually find, proteins or that were changing that we could use drugs to target to try and change what happened with the condition. And that was sort of a real, medical discovery phase. But just even understanding what that process was huge. And that's really helped us understand things like fertility, because what we found was that the tissue was growing in response to estrogen the first part of the cycle. And then after ovulation, it changed and shed eventually when you got a period. So usually all the dead cells that shed would leave your body when you got a period. But if the tissue was up in your pelvis, they couldn't. And the only way you could deal with that was you had to get the immune cells come in. And we saw all these immune markers. And that's very inflammatory. And that's a very inflammatory environment for eggs to be in, but also for sperm to be in, and also embryos. And that's sort of, you've got eggs and sperm and embryos all fighting to become a baby in an environment that's really inflammatory. And, we suddenly could work out how that would happen, and that can impact a little bit on egg numbers and, make it hard further down the track to have a baby. So that's where, if you understand that, you can then think, well, what can you do to change it? And it becomes really obvious that you want to change the environment somehow, either medically with some, medical flushing with something like Lipiodol, or get rid of the lesions with surgery, or take the eggs out of the environment, which is IVF. So, you can sort of figure through the different treatments. So,
it sounds like those early studies really led the pathway then to, the future of where you've headed and what's underpinning the research now. Is that correct?
I think that actually is true probably for most conditions. It's when you don't understand how the condition changes or grows or develops and what the impact of that is on your body, you can't really work out how to treat it or what to do or what it is. And I think those early biological studies really underpinned our understanding, and I think we're getting better and better at understanding even more. And a lot of those biological processes are in lots of different conditions. So that's where we got our diagnostics from, because the difference between endo and another inflammatory environment in terms of markers was the actual tissue itself. And you either had to see it by doing a laparoscopy and doing surgery, which is what everyone had used to do. But as our scanning, as our ultrasound, as our MRIs got better and better, we could actually see the lesions. But, if you'd had an inflammatory condition from another cause, like an infection, or the same markers would come up. So the same pathways were being used, and they weren't specific to endo. And so that's why we went down the track of imaging in terms of diagnostics as well, because we could see inflammatory changes, but they weren't particular to the condition.
Well, that's probably a great time to actually hear a bit more about some of the studies that you've been involved in here recently and continue to be involved in. And what we've done over the last couple of episodes is we've been talking about ultrasound. So we've had Ali Deslans, who who is a sonographer, and we've also had the delightful Dr. Matthew Leonardi as well. Both have been talking about the role that they see in diagnosis for endometriosis. But also what you've been looking at in terms of your study, the Image Endo study, is looking at both ultrasound and MRI and its role in diagnosis for endometriosis. Yeah, so could you tell us a little bit about what Image Endo is up to?
Image Endo is a project that we developed and got funded for to try and use ultrasound and MRI to improve the diagnostics of endometriosis without the requirement for surgery. Because when you have surgery in the mix, it's very inaccessible for a lot of people. So there's this huge delay to diagnosis of, on average, it's about 6.5 years. Mm-hmm. And we really wanted to reduce that, because we felt if we could get a diagnosis earlier, ideally in primary care, without a big surgery. And very few women want to have surgery. A lot need it and have to have it, but most people would rather know without having to go through a surgery. But, you know, in public, you often wait a year or two to get surgery, even if you're on the waiting list. So in the meantime, all the treatments we've got have been designed on people who've had surgery, not on people who haven't, because we couldn't diagnose it. And we really wanted to get better at diagnosing. And we looked at about 15,000 papers to look at all the different diagnostics, and the ones that showed the best specificity were ultrasound and MRI. And they had pretty good sensitivity, which means they mostly picked it up, but a negative scan would never exclude it.
Mm-hmm.
Okay. And we hope to improve that a little bit by putting the data sets together. And we tried to work out how we could do that. And I met this amazing guy called Professor Gustavo Carneiro, who was working at the Australian Institute of Machine Learning. And his wife has very severe endo, and he really wanted to help us. And
Wow.
he really wanted to use AI. He used a lot of AI and imaging to help the radiologists and help the sonographers improve it. And I said, if we could just put these data sets together, we probably can cross-train, because ultrasound picks up endo by the way it moves, and whether the tissues stick together or whether there's a dynamic kind of change in seeing a nodule. Whereas MRI looks at the lesions because there's a lot of old blood in the lesions, and that has iron in it, and the magnet detects it and it comes up as bright white. So you've got a completely different way of looking at endo. And we worked out that we could cross-train and use the ultrasound data to make the MRI data better, and vice versa. And so we ended up having lots of different ways of looking at endo that could help. And you didn't have to, you could have just one scan, either the ultrasound or the MRI, and we could use the data in the algorithms to give you a better diagnosis and improve the accuracy. And at the moment, there's just been a new rebate coming through for endo scanning, but a lot of people haven't had the training to do it.
Mm-hmm.
And we're really hoping that the AI tools we're trying to develop will bring people who've not had a lot of experience in endometriosis scanning, and many people don't know how to do it, back up to sort of a more expert level, so that actually people with endo get the diagnosis very accurately as much as we can. And very brilliant people like Ali and Matthew, who are both on they're CIs on our project, they are getting better and better. The technology in the scans are getting better and better. And the experts are now able to see lesions across the surface of the peritoneum and things like that in a way that even 5 years ago we couldn't do it.
It's amazing. Yeah.
So we're hoping the AI will take that technology even further, and also teach people that we could maybe get some real-time feedback, or allow GPs to upload a scan and say, well, actually they didn't look at it. You know, the scans are very specialised.
So do you mean the radiologist or who reporting the scan didn't look at it, or?
Yeah, either. So the radiologists take at least 2 years to get very good at reporting. And so most of them don't report endo. There's really only a handful that we work with that report endo. And you need a lot of experience to learn that. And we're hoping that the AI will be able to circle areas of suspicion to try and bring up skill sets and give them a bit of a chance of that being endo, so that they can make those calls better and quicker earlier on in their learning. And same with ultrasound. We hope people will be able to, do a scan and the algorithms will say, look, you haven't visualized the uterosacral ligaments well enough for us to be sure that there's endo there or not. Because I think we do get a huge variety of quality of scans. So we've got quality tools that we're trying to develop as well.
When will this technology be in clinical practice, Louise?
We're hoping in the next 5 years to be able to develop it enough that we can integrate it into some of the reporting systems.
Mm-hmm.
Yeah.
So
we're hoping. We've just put a massive grant in that we signed off with on Friday. So
Yes.
hence here today.
Yes. So anyone listening, we please need that grant. Also, just on that, how do you choose between when you need an ultrasound and when you need an MRI, and do you need both?
So I think there are situations where you do need both, but I think the ultrasound is much more cost effective to do in the initial as the initial test. It's not so expensive. But if you don't get one that looks for endo, and you have to scan behind the uterus, and most sonographers are trained to scan above the uterus. And if they don't actually scan in the right position, you will get a standard scan and you will not see endo. It's not that you won't have endo. So I see a lot of patients, and I'm sure you do too, who've got 8 scans over 6 years with nothing on it, and then we send them to somebody who's trained in endometriosis scanning, and there's very clearly endo there. So I think if your scans aren't reporting it, you've got to be sure you're getting the right scan, and we're hoping that the AI will credential the scanners as well, so people will know.
Yeah.
Until that happens, though, are there any suggestions that you have, or how can people tell whether they're getting the right scan or not?
Certainly, as a clinician, saying no signs of endo is not enough for me. I would want the reporters to be talking about the uterosacral ligaments, the sliding sign, or the pouch of Douglas, whether there's movement in the pouch of Douglas. You would expect people to talk about the ovaries and whether there was any endometriosis on the ovaries, that they will have looked along the bowel. And if you've not got that in your report, they honestly should also count the egg numbers, because people with endometriosis are known to have slightly lower egg numbers, and that impacts fertility. And just saying normal egg numbers is not really sufficient. You need to be able to do an antral follicle count as well. So if those things aren't on a scan, I usually will ring and say, you haven't done an endo scan. Can you please access someone? But the tricky part is when you send people for a scan, they can go to bulk build places, which will take the request but not do the scan, and they'll just say no endo seen, but they haven't looked for it. So that's a real issue, and we're hoping the AI will help us with that too, because if we can check the scan in an automated way, we can tell people whether they've actually had the scan, and that's important for the rebates as well. So the training is really, it takes a long time. Yeah.
So, one of the things that Dr. Leonardi was talking about in our last podcast was how he feels that ultrasound, high-quality ultrasound in his lens, is almost an essential part of surgical planning. And in the old days, there was a diagnostic laparoscopy. So you'd go in, have not much sense of what you might find, and you might go in and find no endo, you might go in and find extensive endo. And Dr. Leonardi's take on it is that really shouldn't be happening anymore, or we should be moving away from that. And the diagnostic laparoscopy should be one that is one for the sort of history books. And I was listening to some other podcasts, and it was one from America where they talked about what they called the peek and shriek, which is, I don't know if you've heard that term before, that was new to me, but you open someone up and you go, oh, and then this is beyond my scope. I can't remove the endo that's in here. We're going to, close this person up, wake them up, and we're going to need to book one. And then I heard a story of a patient that I've actually just seen this week who had a peek and shriek scan and should have been referred to a different surgeon, one who had appropriate skills to deal with that, and perhaps a bowel surgeon as well. But the referral hadn't been made, and so there was this sort of further delay in getting this person appropriate treatment, and that's tough. So I guess wanted to make the point that hopefully with the sort of work that you're doing, the peek and shriek will go away. And
and it's interesting. We had an education session with the gynecologist in Adelaide, and that was one of the comments they made, was that they just were not having laparoscopies like that, where they went in without really understanding what they were up against or needing to do, and they would have the bowel surgeons present, and people, And we can also do MRI. So the gynecologist, so the GPs can order an ultrasound, the gynecologist can order an MRI, and most would
to get a
that.
rebate, I guess. Yeah,
Yeah,
so
to get
access
the
of rebate.
Yeah. And so people can privately have an MRI as well. And again, you have to go to the right place because a lot of, and I also see MRIs where the reporting is very wishy-washy and you can't quite work out what it is, and it's somebody who's not experienced at reporting. But we do have very good reporting in Adelaide and very good ultrasound, partly because of our research, because we're using it so much, and the gynecologists and the GPs are using it so much as part of the studies we've done. So Adelaide is quite ahead, and we went to the World Congress of Endo, and our clinical change has happened quite early, which is really good. And the gynecologist was saying, you know, the days where they went in with no information and just had to abandon have really gone, I would think, here. But it's just that you don't have the imaging to support it in some of the other centres. And certainly we work in Melbourne and Sydney, and the Gold Coast is growing, it's scanning, and Brisbane is growing, it's scanning. Western Australia is as well. So Australia's very ahead of the rest of the world. We've been working with collaborators in the UK, and the endometriosis specialist centres don't have scanning. The radiologists tend to drive it. And so London has some radiology-driven ultrasound specialists. They won't do MRIs. The endometriosis specialists do MRIs because they don't have anyone that can do scanning. And technically it's easy to do an MRI. It's just hard to report. The ultrasound, the technical scan is hard to do, and it's relatively easy to report. So it's really interesting because the centres are going to one or the other very much. But the MRI is really, really helpful for some people because some people just have too much pain to have an ultrasound vaginally.
Yeah, that was going to be my next question is when would you choose an ultrasound and when would you choose an MRI in a patient with endo or suspected endo?
Yeah, so I think there are some people who it's too uncomfortable to have a transvaginal ultrasound, so they would need to have an MRI. Or younger people, I tend to think about MRI as well, and we're just not quite so certain how accurate the imaging is in younger people because the lesions tend to be more subtle. And some young people will go to theatre to have a diagnostic laparoscopy and they won't see anything because the lesions are so subtle, but 2 years later they go and have the laparoscopy and endo's present. So you've got to be a wee bit careful in terms of getting a benefit from actually having surgery too.
So you can go too early.
Yeah, sometimes the lesions are really hard to see, I think, and it's hard to get that diagnosis. And then that's not a benefit at all because somebody's now being told they don't have it, they don't need anything, and in actual fact, a bit further down the track, the lesions are much more apparent. So we've got to be careful. And at the moment, we're doing an adolescent study just to try and work this out a little bit more. And,
that's helpful.
It might be better to even look at the imaging at a certain age or...
Because I must admit, I saw someone in clinic just recently, again, who is quite young and who had a high-quality ultrasound, one that I trust, that had really shown no significant endometriosis about 2 years ago. She was in her early 20s. She would have been in her late teens when she did the initial scan and had gone on to laparoscopy without an intervening scan. And there was no endo seen on that high-quality scan a couple of years ago, and there was significant endometriosis found at laparoscopy a couple of years later, which had me surprised, but perhaps that's why.
It could be that. The other thing is we don't pick up the superficial endo very well. So if it's sitting on the surface, you can have quite a lot of it, but you might not be able to see it. So we tend to pick up the tissue any nodules and things within the tissues.
Yes.
And occasionally they're below the surface as well. So the surgeons would miss them. They wouldn't necessarily see them if they're deep in the tissues. So we're just about to write a paper just saying what is the truth. Because even when you look at tissue and cut it, often there's only 5 little sections, and if the pathologist hasn't hit them and when they're preparing it, you might miss it as well. So it's very tricky because I think surgery is not perfect. I think
And pathology is
imaging,
not perfect by the sounds of it.
Ultrasound isn't perfect,
Yep.
and MRI isn't perfect. So at the end of the day, we still have to treat symptoms, and we still have to be conscious that we may have missed a diagnosis, or that diagnosis might come further down the track. And we still have to look at managing pelvic pain.
Oh, for sure.
Correct.
This is a very human field, isn't it? And I think it can be easy to think about this as, oh, well, surely you just make the diagnosis. You just see it on the MRI. The ultrasonographer just does it that way. The pathologist gets it in the right field and all of those sorts of things. But the surgeon should cut it out properly. But you're talking about human beings at every step of the process. And I guess that's the benefit of involving some AI to kind of remove some of that human error.
And it's interesting, we've been looking at the human AI interaction in that diagnostic dilemma, and it's actually better to have both humans and AI. They help each other.
Thank goodness for that. So,
yeah, absolutely.
We've still got a job for a bit longer.
I was going to say, you can't just rely on the machines. There are some decision-making that goes on that humans still benefit the diagnosis. So it is quite complex. And of course, we're only just starting to figure it all out, because it's only been really the last sort of 2016 was the first time a diagnostic ultrasound was described.
Wow.
And imagine how far we've come.
So far. So what sort of things are you finding in the image endo study? What are you finding out from what you're working on?
Well, we're finding out quite a lot of things. Firstly, a lot of people don't have any symptoms and they have a lot of endo. So we actually we needed people who didn't have endo. We were finding so many people that came on our studies had endo that we had to ask people who didn't have any symptoms just so we could get some normal scans.
So like a control group.
Yeah, a control group. And we found about 25% of our control group actually had endo, and some very significant endo.
And that's people, no symptoms.
No idea. People that were, friends and relations and volunteers and university students who were just going to help us out.
25%?
It was really high.
That's a lot.
So, and I mean, it was a group of 50, so one person makes a difference. So, but I think there are quite a lot of people that don't have symptoms, that don't know they've got endo, and they probably come and see me at fertility practices, because it wouldn't be until they are trying to have a baby and it's not working, and that inflammatory environment's affecting their fertility. And so a lot of unexplained fertility, and we've just done lots of guidelines. When you look at the literature, about 40 to 60% of people with unexplained fertility have endo. And in fact, there was a paper only published about 3 weeks ago I think it was out of America, suggesting that was 90% actually. But it really impacts fertility, but also egg numbers a little bit, and early menopause as well. And so,
finding that people with endometriosis are more likely to have an early menopause?
Yeah, they are. So that's pretty good data that came, and certainly that was presented a lot at the World Endo Society. And we see people with slightly low normal numbers of eggs often have endo. And when you look at the follicular fluid, there are inflammatory markers in the fluid, so it can impact the eggs. And we tend to get a variety in the quality of eggs. Some are really good quality, nowhere near the endo, and they're the only ones you need to make a baby. But then some have had moderate quality, or some are quite poor quality, and they've probably been nearer to the endometriosis sort of inflammatory sites. So,
so the closer the nodule or the piece of endo to the ovary, the worse the eggs might be.
Yeah, it seems like there's a differential effect on eggs when we see them in the lab. The question is always, does surgery improve? And we think it does for natural conception. We've never been able to do the studies because we've never had a non-invasive diagnosis where you haven't treated with surgery to be able to see if, in actual fact, the surgery. So we never know whether to do IVF or surgery because we don't really know if that improves the egg quality. But I think certainly for some people it probably does. We know endosurgery does improve natural fertility, so improving that environment. Treating men, so sperm under stress, that are then having to fertilize an egg and contribute to that embryo, in a stressful environment have 2 hits. So actually helping men, look at their lifestyle, look at their diet and exercise, stop smoking will help treat endo for fertility as well, because then the sperms functions well, and the eggs and sperm may be under a little bit of environmental stress, but not as much as if they've already got stress from other things. So there's a lot that you can do if you understand that there's some endo there.
So the men need to, the male partners have got to step up here.
Yeah.
If their partner's got endo or is having trouble conceiving.
Yeah.
I think we need a T-shirt with a stressed sperm on it.
Absolutely. There's another T-shirt.
Well, it can really help if, it's if the sperm can be of high quality in a slightly stressed environment, they just work better.
Yeah.
And it's much, much harder to have surgery and to treat endo than to, look at
stop smoking and cut back on the beers and those sorts of things.
Exactly.
Is there anything besides surgery that a patient can do regarding fertility and endo?
So for example, there's a really good study showing that poppy seed oil or lepiodol, which is moderately expensive, it's a milky substance you can flush through the tubes, and it helps people with unexplained infertility conceive.
Who have
naturally.
endo.
But most of them have endo.
Yeah.
So we're doing a PhD to try and show the effect of it on particularly the immune system and inflammatory markers.
Yeah.
But I suspect it's largely an effect on endo, but that's a theory, it's not a truth.
Yeah.
So we're trying to figure that out, but I think it would help. And then taking the eggs out of the environment helps too. So IVF can help too. And then if you have low numbers, you have the opportunity to freeze eggs or freeze embryos, even if you're not quite ready to have a child, if your numbers are low. And then you get the opportunity to that if you freeze eggs or freeze embryos, they retain the chance of pregnancy of the age you are when you freeze them, not of when you put them back. So you can put them back till you're 53, and they'll give you, your 32-year-old self's chance of pregnancy and low rate of miscarriage too.
Yeah.
So Louise, in my role as a GP, and as you know, I see lots of women coming with pelvic pain who may or may not have had a diagnosis of endometriosis. And of course, when I say the term women, I do want to include people of all genders, so those assigned female at birth as well. And while they might be coming in with their symptoms, often the background context is the question, how much is this going to affect my chances of having a family later if that's what they want to do? And there's a lot of myths out there about what might affect your fertility. And I luckily am too old to spend too much time looking at TikTok and those types of places, but there's heaps of stuff out there. Much of it is misinformation. And there's, as I said, lots of myths. And I was just thinking maybe we could walk through what some advice might be when we see someone perhaps at different parts of their sort of life, when fertility is something that we want to keep in mind or want to try and preserve. And so one of the times when that might come up is in a sort of quite a young woman. So someone who is perhaps in their late teens, even early 20s, who's not ready to think about kids yet, but wants to make sure that they still get the chance later. What do you think is going to help that? Or what would you counsel a young woman like that and probably her mother, who's probably there as well? What would you be talking to that person about, say, the 18-year-old?
Yeah. So I think the first thing that we've actually published a paper on some of the things not to say. And it is amazing how many 14-year-olds or people at uni with no money or, no partner get told to just get pregnant. And that is completely inappropriate, I'd just like to say.
Of course it is.
It's just
shocks me that
really
still happens.
offensive to people. And it just puts a lot of pressure. People feel pressure to go into a relationship or with the wrong person or a 14-year-old, they're just not at a life phase where they would even be thinking of that. So the kind of old-fashioned...
it's just shocking that ever gets said, and I really hope that never gets said anymore.
But I think it's just really important to and that's partly our education, which we really spend an hour talking about endo in medical school training. So a lot of people are not that aware. There are increasing GP programs and tools and education, and the Endo 33 groups are leading the way there too. But it's just some people do get very inappropriate information. I think one of the things that probably theoretically would work is to try and suppress periods, because if you can stop the tissue growing and breaking down and creating an inflammatory response, you're then going to stop the environment being inflammatory, and that might impact egg numbers a little bit, and just not put the eggs in a stressful environment. So I do think period suppression is really important. And I do adolescent gynae, and that's often a very big goal, because I think also every month you get that pain trigger from that inflammation, and that activates a nerve in the back, and you get the organs get sensitized. So you get bladder pain and bowel pain and pain with intercourse. The muscles contract and you get sharp stabbing, shooting pains. And then you get central response to that, which is headaches and fatigue. And I think that if we can suppress periods, those pain pathways don't get upregulated and re-triggered. And surgery is a trigger for that too. You know, if we can downregulate those neural pathways, I think pain is often better controlled. And we have no data. We've not been able to do it until we've had a non-invasive diagnostic, and we're hoping to find out about that in our studies. But we may well find that the environment's a little bit better for the eggs if that repeated kind of inflammatory environment isn't triggered with the period. And we've got very good medications, and we've had 5 come on to the PBS, so they're now very accessible. So hopefully we've got a lot more choice and a lot better ways. And when you think of in the past, traditionally for women, we've actually not had contraception. So people have conceived often when they're quite young and been pregnant for a long part of their life and actually not had very many periods at all. And it's really only been since we've had, you know, good contraception that we've had so many periods to create that inflammatory environment. And I think a lot of people say, well, it's not natural to use hormones to suppress periods and things like that, but it's actually not natural to be having that many periods either. And, you know, I think some of the time the tissue sticks and takes, and then you've got this issue with pain and also fertility.
And so if we have this imaginary 18-year-old with us in clinic who often will have those questions, as you say.
Yeah.
Often mum or dad might be with them and they worry about, should we be giving hormones to such a young person? You know, is it going to increase their risk of things like breast cancer, ovarian cancer? How do you counsel someone around those sorts of things? What do you say to them?
Well, there's a lot of cancers that the pill decreases risks for. So like ovarian cancer is actually lowers risks. There are some people who can't take the pill or can't take estrogen and we can't use it, but we do have different pills now. So we've got a progesterone-only pill. We've actually got another generator antagonist that we can use. And so there are different ways of suppressing periods. The Mirena coil works very well actually in young people, and we use it a lot in our clinics. And although they're hormonal, the egg's making the hormones. Every part of the pill is what the egg does. And we are literally being the egg, telling the brain not to make new eggs. And that's why it works as a contraceptive, but it's also why it keeps the lining stable. And you can run the packets together so you don't need to have so many periods.
Yeah, and I often say to people in clinic, if you're bleeding, if you're menstruating, if you're having a period, that's your endometrial tissue is shedding, which means that any endometrial type tissue that's sitting elsewhere in your pelvis is bleeding too, and that is just setting off such an inflammatory process, and that's okay to do. And one thing I was going to mention is, in my experience in our clinic, and we insert IUDs in our clinic very carefully, and we use topical anaesthetic and the green whistle and those things. And the thing that surprises me is how well really young women who want one tolerate the procedure. So it's the 15, 16-year-olds who want one and are consented, and we really gently and carefully insert one of those, actually cope really well with it and do really well. Obviously, there's the option to go and to do that under an anaesthetic with a gynaecologist as well, but often they do really well. And so you're right, there are lots of different options, and I agree. I just think really important for someone listening at home to hear you as a professor in this area say, yes, that's what I do because it's important and it helps save problems later.
The other thing is that actually there's a new coil being developed in South Australia by Susan Evans, and it's got a pain management system embedded in it.
Yes.
And that's really come from a really good understanding of the pain mechanisms and the basic biology, where we can both suppress periods but also deliver pain management that is going to be right locally where, and we're running that trial at the moment. So we're the only place in the world running that trial with that new IUCD, and we're comparing it to the old one. But, people on the trial have found both, probably both because it's randomized, really effective. And the main problem they have is they don't want to take it out at the end.
Oh, wow, yeah.
So I think there's also, partly we have to develop new medications and accessibility and affordable accessibility to really good medications. But if that gets you to avoid not being at school for 3 days every month so that you're maintaining your education and you can get a really good job, and just the economic benefits of being able to stay in school, to be able to maintain your social network, to be able to get a job that's going to look up, that you're going to be able to support yourself through your life. It's so worth it.
Absolutely.
Just not being in pain.
Yeah. And just being able to think straight even has got to really, the benefits are just so huge in such a young population.
So perhaps if we can fast forward on our 18-year-old, and she's now, say, 25, perhaps she's been on and this happens frequently in people I've seen. They did start on the pill young, and then they went, I want to see what my cycle's doing. I want to have a break off the pill, and they may find that their pelvic pain is increasing. And one of the things that they'll say to me in clinic is, and we're talking about the importance and how helpful suppressing periods can be in endometriosis, and say, yeah, but I want to have a baby later, and I've had friends who were on the pill for years and it took them ages to get their cycle back, and I don't want that to happen to me because I don't want the pill to affect my fertility. Can you talk us through how you talk to someone about that? Because I'm sure you hear that too.
Yes. So the pill shouldn't be doing that. So usually that means they've got an underlying condition where the signal from the brain is not getting to the ovary to tell the egg to grow. And that's actually a very simple problem to solve for a fertility doctor, because we have hormones that can override those mechanisms. But it's probably that actually is, their cycles would not have been regular before they might have been when they started the pill, but something has changed, and either their insulins have got higher, or their thyroid's changed, or it's usually a signaling problem, and we would need to just reconfigure the hormones a little bit to get the egg to grow. But it's usually not endo. So endometriosis causes pain, but most people have regular cycles. Some people have both. So we do find that. So certainly for the pain, you would do a proper endo scan is what I would do now. For the irregular cycles, that tends to go with very high egg numbers and actually be more likely to be polycystic ovarian syndrome. But you can get both.
Okay. Yes, for those unlucky people who happen to get both. So perhaps we can reassure people that, and perhaps you can talk to this, that in general, the different hormone treatments which help aren't going to harm your fertility, and they are rapidly reversible.
Absolutely. So with the pill, it should be out of your system within a month. So if you're not getting regular cycles after that, it's another endocrine problem that the pill hid through that time that you wouldn't have known about.
Yeah. And then the IUD, once it's removed, you're good to go from a conception point of view?
Absolutely. So it should, again, within a month, you should find that the lining grows the way it should normally, and you should be back to what your natural cycle would be. So we wouldn't think coming off the contraceptives, if there's an issue after that, it's something other than the pill or other than the IUCD. And then we have to investigate that a little bit more. If it's endo, we can often pick it up on a scan, but the symptoms are, we can usually pick it up on symptoms, but I just think a lot of people don't ask about them, all those other symptoms. And also a lot of people actually get a lot of pain at school where they've needed time off school, and a lot of people don't get asked that. And so when you start saying, well, what happened when you're at school? Oh, I had to stay in bed for 2 days that's pretty diagnostic of endo. Whereas by the time they get to 20 or 30, I think pain tolerance and thresholds are very high for people with endo because they've just had to live with pain for so long and they don't recognize it sometimes too,
Absolutely.
And some people don't have that many symptoms too. They just have very high pain.
So if our 25-year-old, and we've had to talk to her, we've reassured her that that's not going to affect her fertility long term, for example, say she's been, I'm just making up these ages, of course, everybody's different in what they do. She's not ready to think about conceiving yet, but perhaps we know that she's got endo because we've done a good scan on her. Yeah. And we know that she wants to look to conceive later in life. What are you sort of suggesting for her at that point?
Yeah. So at that point, I think probably the most important thing to know is how many eggs are in the ovary, and we can actually assess that two main ways. One is we can actually, hopefully the endo scan actually counted the eggs, and that tells us how many eggs were in both ovaries that would start to grow in a month that the one is chosen from. So there's this pool of eggs that start to grow every single month that at ovulation, one takes over and stops the other ones growing. And at the beginning of the cycle, you can count them all. And that tells you how many eggs you would be likely to get with IVF if we used a maximal dose. But it also tells someone in a year, you might not have one or two of them. They would go down a little bit. But if you start with a big number, you're still going to get a good number. And that tells you about the numbers. What it doesn't tell you about is the quality, and the only way we really can be sure about the quality is in the lab actually looking.
And so sorry to interrupt. So how many eggs are you looking for? On how many? What's your antral follicle count when you're like, yes, I'm happy with that, and no, I'm a bit worried. If you don't mind me putting you on the spot because I'm interested.
It actually changes over time. So at 25, there should be kind of 20 to 25.
In each, like total?
Total. Yeah. But then in your early 30s, it should be about 20. By kind of late 30s, it should be about 15. By 40, it's about 10. By 42, it's about 6. And by 43, 44, it's lower than that. So you can see it's harder and harder and harder to find the right egg, especially with endo, because only a proportion will be of good quality potentially. They might be affected by the environment. But the other thing that happens is as you get older, the chance of the chromosomes are held on the end of little spindles because a set get taken out just before the sperm comes in. And as you get older, all your cells get damaged, and most of the time you replace the cell, but they can't replace eggs. So that's why you have a pool of them. But those little spindles can break, and then a chromosome goes the wrong way, and you can get a child with Down syndrome. And that happens as you get older and the eggs have had longer to have the spindles break. So age impacts. Endo will affect the metabolism of the eggs a bit. So you'd get some taken out, and then, the environment can have an effect as well. So a lot of people think about freezing eggs now, and we have much better ways of freezing eggs, particularly for some people with endo, the egg numbers are very low. There may only be 6 total when you're 20, and 2 years later, there'll be 3. And doing IVF with only 3, we ideally want about 15 to 18 each cycle. And already somebody's going to have 2 or 3 cycles to sort of get that number. So a lot of people would think about freezing because they might go through menopause earlier and not have the opportunity by the time they meet their partner. And so, particularly if you're having surgery for an endometrioma or an endometriosis cyst on the ovary, because you might treat the cyst and damage some of the tissue.
So you might think to be thinking about freezing before that surgery?
Absolutely. And, most of the endometriosis surgeons would refer to a fertility specialist before they do the surgery. They don't want to impact fertility before they do surgery. So I have a lot of surgeons who will just ring me and say, look, we want to do surgery in the next couple of months. Do you mind just seeing this person? we're worried that if we treat that endometrioma, the egg numbers might drop.
And you were saying there's really two ways for us to assess our 25-year-old's fertility in terms of one's the antral follicle count.
Yeah. And the second one is a hormone called anti-Müllerian hormone, and it's also known as the egg timer test. And that's a hormone that's made just by the cells around eggs in women. And the more eggs you've got, the higher that is. So you can actually get a pretty good estimate of how many eggs are in the pool. And everyone's going to get one a month if they're trying naturally. But if you're going to do IVF, we can say, well, you're likely to get 15 or you might get 30. We have to lower the dose. Or you're only going to get 4, and next year you might get 3. So, but the information we've got can help, I guess, make those decisions. Well, it just gives you the opportunity to choose what to do. So suddenly, if you know you've got endo and you know your egg numbers, you can actually figure your strategy out. If you don't have that information, it's just sometimes it's really hard to come back to it because the numbers are very low. Or if you know that at the beginning, you can go, well, I can choose to do this or not. And
empowering.
Also your conversation with your doctor is different. If you don't know you've got endo, you we'll do another IVF cycle. We don't know what's going on.
Which is what happened to me, by the way, 20 years ago. But that was.
But if you know you've got endo, you can say, well, what treatments are there for endo? I've looked up online, and what about doing this?
I've heard on the podcast.
So then you have a proper discussion as a mature female person.
But if you're saying that some people, this could be an issue early on. So is this a standard procedure that happens, or do you know what I mean? Like if you've been diagnosed with endometriosis or even suspected of endometriosis, you'd want to have this information early so that you can make those decisions. So, I mean, should this be a protocol or a standard, procedure for?
I think it's something we're in a big unknown space because we've not been able to diagnose it. And certainly I would do that in my gynae clinic. I would at least have a discussion and say that there are these tests available, and usually I can give them some idea of numbers on a scan and things. But I think we're doing a big study in adolescents to see if how that, is that a negative effect, finding that information out? Because it just makes you scared and you can't access it anyway.
Yeah, and you don't want to go, you wouldn't want to go too early. Like I wouldn't have that discussion with an 18-year-old, for example, personally.
Yeah. And the egg quality is very good when you're younger too, so you don't need many, but.
It's so nuanced, isn't it?
Yeah, you have to be conscious, that you've got to make sure that it's safe to get a tricky. You don't want to suddenly find that people now are, spending a whole lot of money and they can't go on holiday or something like that too. So it's a very, I think egg freezing came in about as a non-research thing in 2015. Endo scanning came in 2016. We're really only 6 or 7 years out of even being able to figure out how we can do things. And I think a lot of the fertility doctors would be very good at putting the nuances. It's certainly a lot of your choice, but we used to do things like not have a diagnosis of endo, and then you wouldn't get any kind of Medicare rebate if you egg froze. And it was enormously expensive because it was social. And in actual fact, there's a medical reason that you should be thinking, at least if you would access a Medicare rebate now with that diagnosis. So if people were worried that your fertility would be impacted. And we did some modelling looking at just the economic impact of the couples and people who want to have a family that couldn't because of endo. And it's an enormous cost to the community just losing those people in the demographics we're in to society. But we're still figuring it all out is the thing. And we're hoping we've got a cohort of adolescents to hopefully, find out what happens if you get a false negative, or, if the diagnosis is, how traumatic it is to get a positive diagnosis
of endometriosis.
And then what consequences are there? Do people egg freeze? Do they not? Do they worry they should? We're trying to just work out how that would impact people and what resources need to be there. And it's in primary care, actually, that you're going to need to be able to help people.
I mean, and all of these things that we've been talking, most of these things that we've been talking about today are very much within the remit and scope of a general practitioner, and will need to be too, because there's not enough fertility specialists to go around for everybody.
Yeah. We worked out that there were 3,240 gynecologists for it was like 800,000 women with endo. It was just that you can't diagnose everyone by surgery, and some of those gynaes don't do surgery too.
Of course.
So you've got to have an alternative to, and then hopefully I think we've never looked at prevention because it's taken us so long to be able to access surgery to get the diagnosis that nobody's ever thought, well, why don't we look at, we've never done the trials to even see if we could kind of prevent a lot of the pain and also the fertility consequences. So we're just starting to be able to do that, which is, I really think it's going to really, really change.
Yes,
and
huge.
It already has really.
Well, it's so incredible to have you doing this work, continuing to do this work.
I know, so
Louise.
much great science
going
to try. And however, I want to, and I've probably got my own reasons for doing this because I have these questions all the time coming up in clinic. So our 25-year-old, has gotten a bit older. She, whether or not there's a partner, she's decided she's ready to get pregnant, and she's got a diagnosis of endometriosis already. So we know she's got endo. One of the quandaries I have at times is trying to work with people who are ready to get pregnant without IVF, is trying to work out, okay, if they've been doing well on their hormone suppression, they come off, how do you decide? Do you do a laparoscopy before they start trying? Do you let them try for a while and then think about going back? What about the poppy seed oil that you talked about? How do you approach that?
So I think it's really tricky because we don't have pathways established, so we don't know 100% what the best pathway forward is. So I tend to talk about all the different options. So if people, I think it's reasonable to try, if people are ready to try and they come off the pill, a lot of people will get pregnant naturally without needing IVF. And particularly if they look at, then it's look at your lifestyle, you get your exercise up, look at your sugar in your diet, don't drink 40 cups of coffee, cut that back to 1 maybe, and, avoid the smoking and, any drugs and things like that. There are simple things people can do to improve their fertility that even though the environment is a bit inflammatory, it's fine. Some people can't have intercourse very easily because it's painful. Now we have really good physiotherapy for that. And so there are treatments that we can use to help things like, difficulty with intercourse, things like Lipiodol. So I think if the tubes are blocked, and sometimes endo can pull the tubes from adhesions and things, it's important to know that the tubes are open if you're going to continue trying naturally, because if they're blocked, then we have to think about other things, either surgery to unkink them, or they have to think about IVF. So sometimes surgery is a step in there, or if somebody just has so much pain, then surgery is a logical treatment as well, particularly if they don't want IVF. If they're thinking they want 4 or 5 children, not 4 or 5, maybe 2 or 3 children, but their ovarian reserve is a little bit low, IVF is a great option because then you can freeze embryos and you know what the quality is, but it's really more to put some of those embryos back. It's going to be 2 years to have your first baby and another 2 to have your second. And particularly if you're getting towards 40, having embryos there from 32 is really helpful for you, more for your third child. And you may want to freeze eggs or embryos at that point, more to use them much further down the track because you want a larger family. So everyone's going to be a little bit different, and it depends a little bit. Sometimes there are other factors, like if the sperm count's very low, natural conception may be a huge delay, and IVF is going to you'd have to think about it for a male factor issue instead. So it's going to be figuring it out for each individual person. I think egg freezing, I don't know, I'm a fertility doctor, so I'm always going to be, I only see people where it hasn't gone as well. I don't, people who just have a natural conception and the population, you would see people like that, Alicia. I see them when it hasn't worked. So we tend to like to give them more choices, which tends to be, different options. But a lot of people do have a natural conception. And actually my best friend has severe endo and had real problems and did IVF and had her first child, but then her second and third were natural conceptions. And, she's actually had more children than all the rest of us. Yeah. So, you can never say that wouldn't happen with endo. So I would never give up trying to conceive naturally, even if you're doing IVF. Yeah. Sometimes in between, when you're ready to book on, the number of people that have a natural conception, even though they've signed all the forms, is quite high.
Yeah. And as we were saying earlier, I mean, the natural menstrual suppression around having a pregnancy, if you're lucky enough to achieve one, and then breastfeeding, if you're lucky enough to be able to do that, or you choose to do that, can be very anti-inflammatory for the pelvis. And that's where so many, I think, women accidentally treat their endo, and then they find that they have a pregnancy that they may or may not have planned. I have one this podcast is not about me, but I have an IVF baby and 2 beautifully happy surprises. It is funny that we managed to have another surprise after the first one, but thank goodness for that. So, and look, honestly, people like me and you, you've never been formally diagnosed, Cherie, but you probably had some of that.
All the boxes, like you talk about missed school, excruciating pain, and back in the day, that was just part of being female. But also, and so you just had to.
Frustrating because everyone used to get really ratty because he didn't turn up to school and things like that. And,
terrible.
I can imagine the conflict over that.
Back there, he sort of, things get fuzzy, but I just remember that pain so incredibly, like it was just painful and you knew it was coming, and a lot. And again, that typical heavy, like, are my insides coming out of me? But then also interesting, don't mind admitting publicly, early menopause. As well, like there's been a lot of things on the way, and I think that there's a whole generation where
there's also that impact of that because you have to go through another transition, and you don't feel great transitioning into menopause.
Oh, you felt great, didn't you, Cherie? You felt great.
Loved it. No,
it just seems like you get hit, but no one has really recognised that as another impact that people have, and
absolutely.
Look, I think Professor Louise Hull, we owe a lot to you
we do.
And to your colleagues who really were working on this before there was any attention on it. And
with no money.
With no money. Even being a woman in science back then, and you said the term, which, surprised me, they started letting more women into medical school. So such a trailblazer. And both Cherie and I absolutely love when we get to spend time with you. So thank you so much for your generosity today.
Yeah.
We absolutely love working with you and having you around in South Australia. Thank you so much. And good luck with all of the rest of the studies.
Yeah, thank you.
And the funding.
Much.
Give her the funding. Give her the money. Give her the money.
Well, and we very much appreciate all your help. You've been involved in our studies as well, but also it's amazing being able to even be on a podcast like this. 10 years ago, you could not do this, and it's so great that, people feel they can talk about it as a biological condition, and we are really making a big difference. We don't need much money to make a huge difference because the bar is really so low. And, we're really talking about the last 7 years. We're really we're completely changing it, and people are getting, I can see, just having a knowledge base of what's going on for you really takes a lot of fear away as well. So, it does make a huge difference.
Hashtag putting the power back.
So many T-shirts and mugs that are coming out of this podcast. Thanks again, Louise.
Thank you.
Well, lovely to see you again.